Infection, tuberculosis, historical review. Tuberculosis is one of the world's greatest killers. It is common in the underdeveloped countries. Its incidence became rising in the developed countries due to the recent rising incidence of AIDS. Etiology: gram-positive acid-fast bacilli, two types of bacilli, bovine and human mycobacteria. The bovine bacilli carried in infected milk were the source of infection in old age days. Recently, the human bacilli are most common cause of infection in man. Mycobacterium tuberculosis bacilli. Mode of infection: inhalation of droplets from patients of open pulmonary TB, ingestion of contaminated milk from diseased cows, direct inoculation through a wound, an abrasion, or a BCG vaccination. Pathology: the characteristic lesion is the tubercle. It consists of an endothelial cells and lymphocytes collected in a concentric mass around a clump of bacilli. It also contains giant cells of Langerhans type. The histopathology of a tubercle. The histopathology of a tubercle. The details are present at the drawings. Here's the endothelial cells, the morphology of lymphocytes, the giant cell of Langerhans, fate of the tubercle, caseation, fibrosis, hypertrophic tuberculosis. Caseation: coagulative necrosis of the endothelial cells. They become swollen, lose their outline, and fuse in a homogeneous mass of debris. On enlargement of the tubercle, caseation areas coalesce and may lead to formation of a cold abscess. Caseation, caseating granuloma. Fibrosis. Fibrosis occurs in hosts with high resistance. Fibrous tissue surrounds the tubercles and calcification follows the fibrosis. Fibrosis. Hypertrophic tuberculosis. Overgrowth of granulation tissue, scanty giant cells, no caseation. Tuberculous ileocecal lesion is the commonest example. Hypertrophic tuberculosis, hypertrophic ileocecal tuberculosis lesion. Spread, direct spread to adjacent structures, lymphatic spread to the regional lymph nodes, then to other lymph node groups, or to other tissues like tabes mesenterica from intestinal lesions, via natural passages, air passages, urinary tract, or bowel, by blood stream, distant foci, or miliary TB. Clinical picture usually affects children and young adults. Poor classes are more affected due to malnutrition, overcrowding, defective hygiene, and poor general resistance. Recently, the incidence is increasing among the developed countries due to the increased incidence of AIDS. General clinical picture may be manifestations of tuberculous toxemia in the form of appetite loss, weight loss, night fever, night sweats, and tachycardia. Local clinical picture depends on the affected site. Cold abscess, tuberculous ulcer, tuberculous sinus. Cold abscess, soft fluctuating mass lacking signs of acute inflammation unless with secondary pyogenic infection. Aspiration reveals tuberculous pus, caseous material. It is actually not an abscess and not a cold. It's, it is slightly warm and contains caseous material. Cold abscess, tuberculous ulcers. The ulcers are irregular, have a irregular outline with undermined cyanotic edge, and the floor is formed of deficient anemic granulation tissue. Tuberculous ulcers. Tuberculous sinuses usually follow rupture of a deep abscess, usually multiple, surrounded by tuberculous ulcers and unhealthy scars. Tuberculous sinus investigations. Bacteriological examination of the charge exudates and body fluids for tuberculous bacilli. Special stains like the Zeal-Nelson stain, culture on special media like Dorset's egg medium, and guinea pig inoculation tests. Detection of the tuberculous bacilli by the Zeal-Nelson stain, culture on Dorset's egg medium, guinea pig inoculation test. Tuberculin test. It is a good negative test. A negative result excludes tuberculosis, and a positive result is of little significance. The tuberculin skin test. Erythrocyte sedimentation rate, ESR, it is increased, but it is not a specific test. X-ray examination may show positive data on lungs, bones, and kidneys. X-ray TB lung, X-ray TB bones, X-ray TB kidney. Biopsy may be needed to establish the diagnosis. Treatment. General treatment, chemotherapy, improving the general health. Chemotherapy. The use of combination of at least 3 or more drugs is essential for cure of TB patients. Irregular treatment, inadequate drugs, inadequate drug doses, or addition of a single drug to a failing regime allows selective growth of the resistant mutants and acquired drug resistance TB. Contacts of these resistant cases develop primary drug resistant TB. The commonly used drugs are isonicotinic acid hydrozide, INH, rifampicin, and pyrazinamide and ethambutol. Streptomycin is less commonly used due to its toxicity. Rifampicin is hepatotoxic, and isonicotinic acid hydrozide may cause peripheral neuritis. Ethambutol may cause visual impairment. Improving the general health. Tonics, vitamins, good diet, open air sanatorial treatment is needed for patients with open pulmonary TB. Local treatment depends on the affected site. Repeated aspiration in a valvular manner through a healthy skin for cold abscesses, and fixation of procedures for joint affections. Aspiration of a cold abscess in a valvular manner through the healthy skin.
Aspiration of the pus. Just watch the angle
It
of
is
needle piercing. In all cold abscess, pus aspiration to be done in anti-gravity fashion. One can see pus is coming.
good luck and best wishes.